I would like to welcome the first speaker, Dr. Anand Vinekar, who is from Narayan Nethralaya, Bangalore, and who needs little introduction. He will be speaking on how do I structure my organizational activities to tackle technological advancements. Dr. Anand Vinekar, please.
Thank you, Dr. Satyajit. And thank you to AIOC and ARC for this opportunity. It's nice to be the first speaker of a beautiful session. The LDP has always been a wonderful session and it's getting better every year. I represent my institute while I make this talk. And we'll just go. No, we pehla screen. We pehla slide nahi hai. Okay. Let me just go back. Okay. Thank you. Right, so I've been given the talk to talk about how we've sort of evolved in using technology into making, at the end of the day, a better patient experience. So this is just a few of our experiences, and we're still learning. I think technology is always there to grow. So the first thing is what we've changed more recently is the NN Connect. This is like, we hate the word call center because it has a different connotation, but a connect center is obviously the first thing that everyone wants to do is to make an appointment, and that's the easiest after prioritizing what subspecialty and what they're looking for. But a little more, one step further is to actually teach our the people who run the NN Connect to answer a few basic doubts, including things like, if you want cataract surgery, femtocataract, if it's refractive surgery, what form. Now, one wouldn't expect that at a call center level, and that's usually handled by more specialists, maybe in the department, but this is something that has been evolved in training. And I think this has come a long way in helping them sort of understand at the very first interface what they might expect at the institute. And then a lot of the pre-counseling material is sent also on social media, whether it's WhatsApp, because obviously we've captured their mobile number, we've captured their email address as well. So a lot of it is sort of pre-sent to them so that they can ruminate over it at their convenience. The next thing that had a major overhaul in the past few years has been our hospital website. We've commissioned it to, of course, put out all the bots to do a in live chat and all of that. But there's also a lot of information on what kind of insurances and all the kind of practical information that you would want as a patient to see, okay, is this place for me or not? Assuming you've never heard of our institute before, because we do get a lot of patients overseas as well. So that's one of the interfaces, obviously, that they will come across. So these are just examples of screenshots from the website. And then we've realized the power of the vernacular. So I think a lot of the patient education material, be it in complex refractive surgery or VR surgery, or even our outreach programs in CVI and so on, all of it is now done in local language. Now here at this point, some of you all may be aware that the NMC bill is being discussed in Parliament. And if it comes to be an act, a lot of what we are doing might just be on the gray zone of being illegal. So I think we have to go back and see what is public education material and what is promotion to ourselves. The law is very, very clear on that, but of course it's not yet been passed as an act. And I think it's important to be sensitive to it in the coming few months. Social media obviously goes without saying. The reviews and the feedbacks is something that's extremely important. One never coerces or forces any patient to give it. A lot of it is done spontaneously, but again, this has come under the radar of the government. Possibly this might be assumed as
Initially, I had
illegal
looked up in Google,
case you are
and this hospital had great
promoting.
reviews.
Promoting yourself through the social media. So you can give information saying this is what I can do, but at no point can you say that I'm the best, you need to come to me. Even sometimes providing a contact number or helpline number may be in the gray zone. The next 6 to 8 weeks will tell us, because by June 22nd, the government is closing all of the comments and then we'll discuss it in Parliament. Third-party surveys are good because they seem to be better than being a more biased feedback that we might have even cajoled our patients to do. And the promotion of this, if it is published, especially in the public space, is not considered advertisement. So this is something that we might want to know and look at. Now, EMR, I think all of us have, there is unfortunately no perfect EMR, but what we're trying to do is integrate patient information with all the diagnostics. So sitting in one place, we are able to see not just their current, in this example, Optos scan, but even serial, Humphrey's visual field or their OCTs and so on. So you don't actually, the doctor doesn't have to move into the diagnostic room, but has to sit there simply and just open up with logins. Unfortunately, a lot of these licenses are expensive. And if we have 9 adult retina surgeons, so procuring 9 licenses sometimes is expensive. So one has to look at the cost and the benefit as well. But if you're a slightly smaller group, then it works really well. Now, I was talking about technology and patient safety. I think a lot of us already do all these hospital OR activities, but it's important to display them. It's important not just from an NABH point of view, but from the point of view that your patient safety, your surgical safety comes paramount. And a lot of green initiatives we've started in. We now have 4 hospitals, 4 campuses rather. The 5th one will be commissioned by the end of the year. Again, it's in Bangalore City. So, and I think all of these are across the board, and this we are doing voluntarily and not because of any statute. This is a very cool piece of research that we did with Indian Institute of Science, where we looked at the shadow photography in a very high speed. This, of course, is the very early part of the pandemic where all of us were worried about aerosols and liquids coming out. So that's the air puff and that's the vitrectomy. This was animal studies, and then just to show what distance and what kind of cannulas you need to know to put in just to avoid aerosol spread, because at that point of time we were looking at COVID-19. Technology and social responsibilities. This is a program that I lead. So this is, for example, using outreach, using subspecialty care into the outreach. And that's really important because otherwise the standard of care is only when they come to you and you really want to provide it right down there. So for example, the camera that costed about $110,000 is now about 10 or 12 lakhs, after coming down into innovations under the Make in India scheme. And we are proud that this is now having a CE and FDA approval and has been sold in more than 200 countries. And this is the publication. So it's really important to publish your technological advances, because that again, in the new NMC bill is considered perfectly legal. And then this is something that we're really proud of, and we're also really proud of the fact that we have funded our own research with a few exception of few DBT grants that have happened in the past maybe 3 years. All the profits that have got from the hospital have been plowed back into research, and we have some really good state-of-the-art labs where we collaborate with a lot of doctors across the country. It's not just meant for ophthalmology now, it's also part of the larger health city that we share our campus number 2 with. And we are also now commissioned to start gene therapy, which should have started 2 years ago, but is now happening this year because of the delay in the pandemic. Now here's an example of how you can use artificial intelligence. This is one of the PhD topics of one of our fellows turned consultants in how to actually improve your patient enrollment. So what they did was basically looked at all these factors and they looked at a lot of the demographic and their clinical data, and they ran these scores. This is, I think, probably in print or has been accepted for publication. So look what's showing up. What are the kind of factors that would influence a patient to take up a particular type of surgery or a premium IOL or a premium kind of refractive surgery based on their demographics and their clinical findings. And I think this is pretty important because you can integrate this into your practice. You can actually realize and sort of channel out more information and resources to those patients who might end up as your premium patients. It's not to say that others will not be cared enough, but this is just to flag those patients who might need to be fast-tracked or shown more information in a shorter period of time. And of course, every institute, all of us have the X.
Kandita, actually, I'm
just going to mute that. But we've started a reversing diabetes clinic. A reversing diabetes clinic is something where we've integrated. Working with physicians and diet. My chairman leads this himself. He initially turned from vegan to now high-fat, low-protein diet, and a lot of reversal of diabetes, especially in our chronic conditions. We are now looking at diet as a control for chronic inflammatory conditions in our uveitis department, glaucoma department, retina department. So this is just one way of integrating holistic care, and this may not be technology as the way we understand it, but certainly something that benefits our patients and draws the extra set of patients, because because you're now collaborating with physicians, endocrinologists, diabetologists, and what have you. And then we also have this holistic healing center, which is integrating all kinds of relaxation methodology. It's not just for CSCR. There are so many conditions, especially chronic conditions, where a peaceful mind and a healthy mind will give rise to a better outcome, even it be in ophthalmology. Thank you very much for this opportunity.
Thank you, Dr. Anand. Dr. Anand Vinekar is not only a national but a global authority on ROP. And we are very, very proud of him for the amazing work that he's doing in India. A lot of the things that you showed involves a lot of cost, the initial part that you showed. What would your message be to the average ophthalmologist pan-India of how to make use of the technology without the cost part?
So actually, honestly, except the laboratories, which have taken 12 years to set up, none of it is really very expensive. I think almost all of us have websites, almost all of us have social media handles. I think it's just the way we tweak it. And again, I wanted to raise the caution because the NMC bill came out only last week. And until then, we were just sailing along, believing that putting in YouTube videos and creating social handles was the way to go. But we might just have to rethink it. And it shows us how we need to adapt to the situation. And so I think, no, it's not very high cost. It's just about using your own resources in a better way. The idea here, we've always had a website, and if those of you who have visited our website 5 years ago and seeing it now, you'll notice the difference. And I think it involves some amount of professional help, but you have to guide them on what you want as an outcome. And I think that is important. So if you know your patient demographics, if you're in a city vis-a-vis a town, or if your predominant practice is specialty like retina versus cataract or refractive, you will obviously tweak your website to do it differently. So I think not all of it is high cost at all. In fact, a lot of it is very low cost. And I only put the labs in the end because, yes, that is our USP. And we started with very, very small projects. In fact, the AI model, refractive, which Dr. Rohit leads, that's no cost at all. I mean, it's just taking in demographic details from an EMR and then looking at it prospectively after looking at the retrospective data and then feeding it into an AI model. There are wonderful AI sessions this AIOS, so I invite all of you all to come and see that. But no, I think it's just understanding what you want out of the system. So it's not always high cost.
Thank you. I understand Dr. Sanjay Chaudhary sir also has used a lot of technological advancements in his practice. What are your views, sir?
Okay, so it's actually the field of the youngsters who are very electronically savvy, and they are the ones who lead this field compared to the senior generation who are not that savvy.
I know your son is doing more.
Right. Okay. But then from his experiences, we realized, which would be very useful for the young developing doctors, that there are two elements which were doing very strongly, which was Google Ads and YouTube. Right. Google Ads involved fixing up a cost for that thing to come up, and YouTube was actual social media marketing. But his experience I can share with you is, we realized that Google ad was no use. It was really not working, but YouTube promotions really work. If that is of use to the people, if they want to save their money, spend it in an area which has a greater impact than this side.
Thank you so much.
Thank
you
you
so
one
much.
thing, sir. Yes, that's exactly what we believed and we did. But that's, I believe they call it search engine optimization. And that is exactly what has been named as illegal in the new NMC bill. There is actually a subdivision saying that any kind of tweaking of social media to make your name appear above anyone else as a competition, while you can do it if you're a restaurant, we are considered differently, which is kind of odd because we also come under the Consumer Protection Act, but that's a separate debate. So I think what we used to believe as true just 2 weeks ago, we might have to rethink. In the time when I made this presentation, and what I'm saying now seems to be so contradictory because that's how fast the scenario is changing.
So, Dr. Anand, the search engine optimization could be either by an organic form where the organic growth takes place, or it could be a paid form.
Yes.
So
the paid form has been
come under this thing, but the organic search engine optimization would still be allowed.
We will have to wait. I believe the IMA has written to the government for changes. So I think we'll know by the end of July.
Just one more query is, the legal implications, like you said, I think they differ for an organization under a company and for an individual. I believe as individuals, the advertisement is against the MCI code. But as a company, as an organization, I think it's more liberal, I believe.
Yes, because there's something called the Clinical Establishment Act. If your state has not got a separate act under your, like Karnataka has a Karnataka Private Medical Association Act, so we don't come under the CEA, but Maharashtra, I believe, does come under the CEA. So their organizations have been exempted from individuals, but that is no longer going to happen. So in the what they have defined as a healthcare provider, it goes all the way down to a mohalla clinic, a private practitioner, a government, anyone. In fact, it's crosspathy, which is allopathy, homeopathy, all of that is all come under the same umbrella. Although it may be dealt with under two different bills or acts, but now anyone who provides healthcare services, diagnostics, investigations, all of them are now come under the umbrella of healthcare providers.
Thank
So
you,
I
Doctor.
think-
Thank